Excited to be here with everyone today to kind of discuss ACL injuries, a big part of my day today with my role. Here are some objectives that I'm hoping that can come across today, everyone feels comfortable with. First, just identifying what an ACL is. It's something we hear a lot about on TV. It's a common injury that we know in a lot of athletes. So probably some of your favorite athletes may have dealt with this before. So contributors to that, essentially, what are our options after an injury from that? How we kind of look at the rehab process, and if we get you back to sport, hopefully keeping you on the field and not dealing with an injury again. So as Jeff mentioned, I'm a sports physical therapist and athletic trainer. I work for NovaCare in Philadelphia. I have a unique position that I split my time between a clinic population and then with Temple University athletics. I spend about half my day with Temple University football. So being an athletic trainer and a sports physical therapist, I'm in a unique position where a lot of times I'm with athletes the day they get hurt, all the way through the rehab process to the day they get back to their sport, which is fairly unique. So I feel like I have a good appreciation for all the ups and downs and things that come along with that. So why are we talking about ACLs? As I mentioned, it's an injury that we were all probably familiar with or at least heard of. Some of the bigger names in athletics have dealt with this, and we all know it's something, once you hear that, that athlete might not be on the field for a period of time. Before we get into specifics, I think it's just important we kind of identify what is an ACL. And so anterior cruciate ligament. So ligament means bone to bone. So essentially when we have our joints, in this case, we're talking about your thigh bone and leg bone, and the ACL is one of the ligaments that attaches the two. And ligaments help provide stability to the joint. More of a passive kind of stability, meaning if we go to move it, if you feel kind of a block or a restraint, that's usually the ligament that's stopping that. And those are made up of collagen and fiber, which allows it to be both flexible and tensile, which is one of the reasons why it's dynamic and helps us provide our knee, in this case, with the control to kind of go through athletic types of injuries. So the ACL starts on the femur, the lateral portion of your thigh bone, and then runs down to your lower leg bone on the inside. And it actually is in two bundles. So we have kind of a back forward portion and a back portion, and they kind of run down diagonally. So I always kind of remember it's kind of like you're holding a pen and it comes down to that angle. It has a blood supply and then a nerve supply. And the blood supply is what helps keep the tissue healthy. It allows it to kind of keep moving. And then the innervation lets us know that the nerve in this ligament is providing feedback. So in this case, the ACL is really important for what we would call proprioception, where the ligament helps let our body and our nervous system know where we are in space. Here I have a couple of drawings in which you can kind of see that. So the ACL runs here. So we kind of talked about this. In this case, this would be the front of your right leg. So we have our lateral femur and then the medial portion of our tibia, and it runs down this way. And this is what it looks like on a cadaver. So kind of running from the outside of the thigh bone down to the inside of the leg bone. So essentially, it's a piece of tissue that runs from the thigh bone to the leg bone. I mentioned that it plays a big role in providing stability to the joint. In this case, it helps stop internal rotation, so the turning in of the knee, especially as we get a little bit straighter, and also can play a role as our knee gets a little bit in a bent position, blocking a turning kind of thing. So you'll notice when we go through some of the injury mechanisms why understanding those mechanics is important. So here I have a little bit of a schematic. Once again, we can kind of see, once again, thigh bone, leg bone, and you can see as the knee bends, this tissue down through here comes and becomes taut, which is why we'll see certain positions in which you're more likely to injure it. So too long, didn't read. Essentially, ACLs are ligaments, which is tissues that run from bone to bone. In this case, we're talking about thigh bone to leg bone. But we're here talking about this for, on a Tuesday evening. So it must be a little bit more complicated than that. So really, what's the big deal? So the thing that translates or is important about this is we're talking about a ligament. We have a lot of ligaments in the body, but in this case, we know about 200,000 ACL injuries occur per year in the US, and of those, 150,000 will be reconstructed. So it makes it the sixth most common orthopedic procedure in the United States. And the interesting about ACLs, when we think about certain injuries, maybe you're playing sports, you get hit or something like that, but about 70% are non-contact, meaning that you're not coming in contact with another person. You put your foot in the ground and something happens, and then that ligament goes on us. That doesn't mean all occur that way, but the vast majority are non-contact, but you can still have contact injuries. So what are the things that happen that cause this to occur? So the ACL during a deceleration and accelerated motion, so essentially speeding up and slowing down, a combination of that versus with a big pull from the muscles in the front of our thigh, our quadriceps, and maybe not enough capacity or strength in the muscles in the backside of the leg, our hamstrings, can kind of create this shear force. And eventually, if the ACL doesn't have the capacity to handle that and the forces exceed its strength, then the ACL will kind of tear. So we know when it comes to this, there's an internal rotation of the knee, so we're turning in. A valgus load is, which is when the leg kind of drops past midline coming in, and then that excessive knee valgus during that slowing down is kind of a recipe for disaster. I have a video here that'll help us kind of break it down in real time. Ooh, geez. Geez, for the delay while I try to get this to work. So unfortunately, it doesn't look like I can get the video to play, but I think this gives us enough information where we can see. So if you're moving in a dynamic position, we mentioned thigh bone, leg bone, that kind of turns in. So we would call that internal rotation. And we mentioned the ACL stops turning in motion, but that's when your foot's not on the ground. So once you're kind of planted, if our foot turns in, our lower leg turns out, and our thigh bone turns in, we create this valgus force where the knee drops in. And that puts too much strain on the actual ligament itself. And then if you don't have the muscular capacity to slow those things down, there's some thought it might be just one instance. It might be this happening over hundreds of thousands of time, and the ligament doesn't kind of loses some of that stability. The more you do something, eventually we see that kind of tear. So what's kind of the story that we hear when this happens? So we know there's this mechanical instance. Most of the time people will describe it as like, I put my foot in the ground, I felt my knee buckle. They'll often hear a pop. And a lot of times within about a day or so, they'll start getting a big joint effusion or joint swelling. There are instances when it's not so obvious. People might be like, yeah, my knee feels a little funky, but like I was able to walk it off. It's not that bad. And then you find out a little bit later that maybe they did tear something in that instance. But I would say if you're a layperson and you have a friend or a family member that talks about going out and playing soccer and they notice a buckling and a pop and their knee swelled, that you should assume that they have some sort of ligament injury until proven otherwise. And it would be good to seek the opinion of a healthcare practitioner. All right. So it is a big deal. It's the tissue that attaches bone to bone. But in the case of ACL, it's one of our primary restraints during deceleration and cutting and pivoting, which is a lot of field sports. And we do that often. So that's one of the reasons why we see so many of them in and at different types of field sports like your soccer, lacrosse, American football, things of that nature. So this happens a lot. It's just a piece of tissue that attaches bone to bone. It should be pretty easy just to say, can we just make this not happen? So there are some risk factors, some modifiable, some non-modifiable, meaning there are things we can work on and change, and some stuff isn't necessarily in our control to change. There are some anatomical ones, and essentially the slope of your thigh relative to your leg bone can play into it. If it's a little too shallow or too steep, that puts more stress on the ligament itself, and that can play into it. We know having a little bit more laxity in the ligament itself, so it might be a little bit looser than someone else. That might predispose you to this. And then I mentioned earlier that you may have maybe a type of muscular imbalance where if the front of the leg bone pulls too hard and the muscles on the backside don't have the capacity to handle that, that might result in it as well. Or it might be just a timing issue, which is something that's hard to train. There are genetic factors that play into it. We know that females, depending on what you read, are somewhere between 4 to 8 times more likely for this to occur. It's much more likely if you're in a younger age, and also you're more likely to re-tear your ACL if you're a younger age. Now, it might not necessarily just be the fact that you're young that plays into it. We just know that if you're younger, you're probably more likely to do some higher risk activities, whether it be playing a lot of sports. If you get hurt and want to get back to sports, that might predispose you to it. I'm in my mid 30s. I know if I tore my ACL, whatever I did doing it, I'm probably just not going to go back to, honestly. And then there's a family history component to it, which probably ties into some of the anatomical things we mentioned there. Genetically, you're probably going to be similar to your parents. If they have a history of ACL tear, that might predispose you to it. And the reason you're predisposed is your genetic makeup and or anatomy might play into it. So back to that idea of like a shallow or narrow slope. Other factors that you'll hear kind of discussed out there, is weather at play, whether it be wet or dry. There's been a lot of talk specifically in the NFL about playing on turf versus grass. Does that predispose you? And you'll hear this kind of swing back and forth. As far as grass versus turf, it doesn't seem that there seems to be a huge issue, but I feel like that's a debate that'll go on for a long time. And then there's probably a few more that we'll discuss further as we get into like some of the things we would manage from a physical therapy component. So we've established ACL tears happen a lot. They happen a lot in sports because we do a lot of cutting, pivoting, and deceleration. There are some things that we can maybe control, some things we can't. So say this does happen to you, unfortunately, or a family member or a friend, where do we kind of start to go from here? Like, what are our next steps? So essentially, after an ACL tear, you have two main options. One would be to operate, and the other one to be not to operate and just go with a non-operative physical therapy rehabilitation type of management. And I just want to talk through a couple of those and give you an idea of like how we would manage one versus the other. So you don't see it quite as often in the United States, but in Europe, it's very common to go for a non-operative management of an ACL tear. And there are patients that are probably more suitable for this. So those with mild instability, meaning that they don't feel a lot of shifting and or like a lot of buckling with that. Those that are not necessarily looking to get back to high risk sports. I work in collegiate football. If we have someone that tears their ACL and they want to go back and play football, generally speaking, we would probably say you want to get that reconstructed. But if you're in your 30s and you got hurt playing like rec soccer and you're like, hey, I just want to get back to the gym and run, this might be an option for you. It doesn't mean that all situations like that work out, but something that you can kind of trial through. And then we also know that there are people out there that just don't love the idea of going and getting surgery. So they might be ones that are more likely to kind of work with this. We have studies that show about 90% of ACL deficient patients, meaning people without ACL, that were treated non-operatively, were able to continue participating in sports about 12 years after that injury. But the big thing that plays into that, it's the type of sport that they're going back to. So only about 1/3 of those people are really playing cutting, pivoting sports versus maybe just getting back to like downhill skiing or jogging or running for fitness. From a rehab standpoint, how do we manage a non-operative patient or an ACL deficient patient versus an operative patient? You'll hear this as a common theme as we continue forward with today's presentation, but a lot of times we're looking at milestones, not necessarily just time. And those milestones are going to be indicative of how your knee's functioning and how you can handle some of the activities you're looking to get back to. How does your knee move? What's the strength and capacity of that? How do you handle more dynamic maneuvers that are going to be something you're going to be exposed to during higher level activities? And we have some decent data as far as screening for what we would call copers. So if you were to tear your ACL, we decide to start managing it, and you notice that you don't really have any of this major instability, so no buckling, no kind of shifting. And then we can get you to a certain point where you can pass some strength and hop tests that we'll discuss a little bit further. There's a good chance that your body learns how to function around the fact that you tore it. So we have a lot of redundancy built into our anatomy. So in this case, the ACL is a restraint that stops kind of the thigh or the leg bone moving relative to the thigh bone, a big role in some of those rotational capacities, but we also have we have muscles and dynamic stabilizers that do that as well. So we can train those things to handle the loads without that. A lot of times you can get back to those activities. Now, once again, there's certainly patients that won't fit in this, but it is an option and something that if you end up getting hurt and you're having a discussion with your orthopedist or physical therapist, it's something to kind of consider. I think one of the big things to take from this is that we know if you give it about 3 months, you might have people that are not necessarily what we would define as copers, and sometimes they turn into that. So you might want to consider the amount of time you're dedicating to managing this before you make a decision on do I or do I not need surgery. So having said that, the vast majority of people in the United States are going to end up going and getting some sort of surgical intervention, most commonly an ACL reconstruction. There's two major types of ways you can go about that. An allograft, meaning you take tissue from a cadaver. So you would take an ACL from a cadaver and put that into the leg. You don't see that as often, and we'll talk about the limitations of that procedure. Or more commonly, you'll see what's called an autograft, meaning you'll take tissue from another part of your body and use that as your ACL. Other things to kind of consider when you go in operative management is when you hurt your knee, you have an ACL tear, There are many instances when the ACL is not the only thing that gets injured. You might have other ligamentous injuries, maybe your MCL, like the ligament that runs on the inside of the knee, meniscal pathology. So those are the tissue that's between the two bones that helps kind of cushion. It's very common for you to also have an injury to the your meniscus. And then you might also deal with chondral issues, which are the surface of the bone. You can think about the surface almost like a road, and sometimes you'll get these little potholes in it. And sometimes those can cause issues and lead to some complications after surgery or just making things a little bit more challenging. So main operative management is going to be either some sort of autograft. More commonly, you have the option for an allograft. ACL repairs are coming more popular, mostly studying more of the pediatric population. Still, for the vast majority, I've worked about 10 years. I've only seen one real ACL repair. The vast majority of people are going to end up with an autograft. So that's what we'll focus on today. So you decide that you're going to get surgery. Then the next question becomes, what type of graft are you going to utilize? And there's three major options. The first is a bone, patellar tendon bone. So your surgeon would take a piece off the end of your kneecap, your patella, the tibial tuberosity, so the little bump on the front of your knee, and then cut out the middle third of your patellar tendon, which is like the tendon that runs from your kneecap down to that position. And one, if you kind of bend your knee and you feel it pop out, that's the one that we're discussing. There's also the hamstring tendon. So if you feel like in the back of your knee where the little tendon pops out, they'll often take from the medial tendon. And then the last option that you'll see nowadays, which is becoming a little more popular, would be a quadriceps tendon graft, which is above the kneecap. So rather than taking from the bone and the bone between the patella and the tibia, your lower leg bone, we're taking the end of your quad tendon, which is essentially your quadriceps muscle, the one in the front of your thigh, as it comes down to the top of the kneecap, not necessarily starting at the bottom of the kneecap. Now, all autografts have similar return to play and re-injury rates. So there doesn't seem to be one gold standard. You may see one option utilized a little bit more depending on where you live, the type of sport that you play. But the big thing is when it looks at from like a clinically significant difference, there doesn't seem to be a big one. The big thing is they all have trade-offs. So when you're going and deciding that you're going to take either your patellar tendon, your quadriceps tendon, or your hamstring tendon, that might change certain things we need to focus on in rehab. Because when you're taking tissue from another part of the body, we have to also consider how we're going to rehabilitate that area as well. And I had mentioned earlier, there are some limitations to the use of allografts. And the big thing is that there is well-documented higher risk of re-injury with allografts. So unfortunately, even with an ACL reconstruction, about 1 in 5 people might end up with a re-tear. But we know that almost doubles in the presence of an allograft. So if you're going to take something from a cadaver, outside the other high re-injury rate, there is a small chance that people's body may reject the fact that they're taking out foreign tissues, not their own tissues, and come in. So you can end up with infections or other kind of issues. So you will see allografts from time to time. I see them way less nowadays than I did when I first started working. There's probably a small section of people that have this instability. They need some sort of option, and maybe they're not looking to get back to certain things, and that is a consideration. But I would say for the vast majority of people, looking at an autograft would probably be the primary way to approach these. So we've kind of established these injuries happen a lot. When they happen, we have a few courses of action that we can go to as far as trying to get a surgical intervention or just managing it yourself. One thing I want to touch on, which I don't think is really appreciated at times, is how are you going to now deal with the fact that we're talking about an injury that takes a long, long time to kind of manage. And we've all kind of appreciate this. If you think about a professional athlete on maybe on one of the teams that you like, a lot of times when you hear ACL, that person's going to be out for an extended period of time. They're at least gone for the season, maybe a little bit more. And we're talking about people with all the resources and their job is just to get healthy. As a lay person or someone that's just recreationally participating in things, like you don't even have all those resources. How long is it going to take for us to get back with that? So we'll get more into specifics later, but generally speaking, if we're talking about something that takes 9 to 12 months, how do you manage these things around things like your insurance plan and benefits? You might have a certain amount of physical therapy visits for the year. So if you get hurt in the fall, those might re-up at the new calendar year. So you might be able to stretch those out a little bit more. But if you get hurt in January, now you got to figure out how to utilize the benefits that are supposed to be spread out for a year over the course of 12 months instead of maybe 3 months and it re-upping. So things I think it's important to have conversations with your PT with. There might be periods of time where it makes sense to kind of utilize some more of your insurance benefits, and other times when we might be able to set you up with a program in order to try to manage that. And also being realistic with the consideration of, depending on what plan you have and the utilization of that, and you might have limits. Maybe your deductible is very high, or maybe you don't get a lot of visits. You might need to consider other out-of-pocket costs that you might need to manage. So it's often recommended now that we do some sort of pre-op phase coming in, and we'll get into the specifics of that. But this is a really good time to sit down with your PT and kind of scope out, hey, from now until I get back to sport, what are we kind of working with, and how can we kind of go about that? And I think it kind of helps set expectations and helps us be more mindful of how we're going to go about these things and best utilize them. So we're talking 9 to 12 months. I like to kind of think of it as 4 quarters in a game. So from a more simplified term, we can consider your pre-op phase, your early, your mid, and your late. And then that last step would be return to sport and performance. But when I'm working with patients and I'm trying to get them in the mindset of what we need to do, first quarter is just normalize activities of daily living. We got to get your pain down. We got to get your knee moving like a knee. And we need to get you comfortable just walking around and being a normal person. I work at a college. Most of the time, I'm like, I'm not worried about you being a football player right now. I'm worried about you just being a normal college kid that has things that they need to do. And then we can kind of start considering those other things moving along. After about maybe 8 weeks, upwards of 4 months, is when most people are going to be like, hey, I don't really notice it all that much from day to day. Maybe some things here and there, but your normal day-to-day life, if you're talking about not things that aren't necessarily physically demanding, you're going to feel pretty good. So after we get through that first quarter, we get to the second quarter, and now the job is going to be, all right, we got to get you running again, generally speaking, just in a straight line, and we got to start thinking about getting strong. After surgery, your body takes a big hit as far as the things that it needs to kind of build back up. And this kind of second quarter is where you're going to work on a lot of that. After we get to, now we're in like kind of halftime. So for the most part, you can do a lot of the things you would want to do. You can live your normal day-to-day life. You can run and work out, but we're still in that phase now where we're like, all right, now we got to teach you how to be an athlete again. We got to start making things a little bit more dynamic. We got to bring up the intensity. We got to start exposing you to stuff that maybe we would say in the short term we should have avoided, but now's the time to start easing yourself into it. And then lastly, we got to consider, how do we get you back on either the field or the court safely and get you feeling like yourself again and minimizing your chance of getting hurt again, because these take a really long time. The last thing you want to do is end up with a re-injury and restarting this entire thing from the start. Excuse me. So here's kind of our timeline. Sitting down with someone, letting them know this is what we're looking at. We're going to break it down into the 4 quarters. Usually during the early phase, I sit down with the patient, and at some point I say, we're going to be together for 9 to 12 months. Something's going to happen. It might not be a big thing. It could be a small thing, but that's so much time together between the rehab process, you just living your day-to-day life, things happen. So it's going to be my job to make sure, A, when that happens, I keep you calm and we do a little damage control and get you back. The vast majority of the time, these things aren't big deals, but I've just worked with so many people. And if you have 12 months, you're going to run into something at some point. If you don't, I'm usually in the back of my head, like, when's the thing going to come? So I think it's important to kind of set expectations for people. It's a cliche, but it's marathon, not a sprint, and get people prepared for all the things that are coming forward. So big things we need to consider now would be this combination of time versus functional milestones. And it's not that one matters and the other doesn't. We need to keep both into account. Now, years ago, it used to be just much more timeline based, meaning if you hit 6 months after your surgery, your physician's going to say you're good to go, and then you go out there. And nowadays, I would say that's going to be recommended against the vast majority of the time. So from a time standpoint, we have biological considerations that we need to take into account. So I mentioned before, most people are going to end up doing some sort of allograft. With an allograft, we're taking traditionally a tendon, so most commonly that patella tendon, hamstring, or quad, and now we're going to put it in a new spot in your knee. We need it to learn how to be a ligament. That's not something that just happens right away. And conceptually, when you stop and think about it, you've had this thing for, depending on your age, has done one job your entire life. and now we're going to put it in a new spot. It needs to learn how to do this new job. That's probably not something that's going to happen overnight. And that's where we know this kind of 9 to 12 month range comes in. Biologically, your tendon goes through what's called ligamentization, and that takes a certain amount of time and not something we've necessarily found that we can speed up with particular things. The body's just got to kind of figure that out. So that's one component. That's why time is important. With time, we also need to consider the functional kind of milestones that we need you to hit. After surgery, you develop pain, you have swelling, your knee won't move like it used to do, you'll lose a lot of strength and capacity. And with all those things, it's going to make it really hard to get back to sprinting, jumping, cutting, all the stuff that we normally know comes in with that. So if we look at both considerations, I'm saying it probably takes 9 months plus for that tendon to learn how to be a ligament, but that's just not sitting at home waiting for that to happen and then going and playing in your sport. We need to physically prepare you as well to get back to those things in order to do it safely. And we have pretty good data of why those things are important. We'll talk about that a little bit more specifically later. So it's not an or, it's an and that we need to be mindful of in the situation. So prior to surgery, as we kind of look through our phases, we first have our preoperative goals. And the big thing that we need going into surgery would be what you'll hear described as a quiet knee. So that means little to no swelling in the knee, full range of motion. In an ideal setting, you're going to have strength that's over 80% compared to the other side. We have some studies that show that'll kind of set you up for success on the back end. And back to what we kind of considered before, if you're in this between of do I go a non-operative route, do I go an operative route? There's not necessarily data to suggest that delaying surgery has any major negative impact, assuming you're staying within reasonable activities during that time. So say you want to say, I'm going to give non-operative management about 3 months to see where I'm at. And at that 3-month mark, you decide, you know what, it still just doesn't feel right. I'm going to get surgery. You just spent 3 months preparing your knee to be ready to handle all the things that come in. Because after surgery, everyone's going to take a hit. And the better you are going into surgery, then the more we're kind of working with as we go in. So something to kind of consider. Quiet knee, as strong as you can getting in, and let that takes as much time as it takes. And during that time, you might realize that one option might be more appropriate for me than any other. So at this point, we've maximized, we've hit our preoperative goals. Now we're going to start getting into some of our early management of ACL. So this is from a paper that's kind of discussing like maximizing our early outcomes after ACL. And I think these 6 things are like really important as far as our goal setting and back to like controlling this kind of first quarter for people. So after surgery, pain and swelling are big limiters to our ability to do things. We need to just let the knee kind of settle down. From a physical therapy standpoint, we have different types of modalities, hands-on strategies, and other things that we can utilize to try to make this as smooth as possible. Getting your pain down, getting your swelling down, because all these things kind of influence everything else as we kind of move through this path. So we need to start moving your knee. The most important thing is getting your knee straight. If your knee doesn't get straight, it can get arthrofibrotic, which sometimes means it won't get straight without the surgeon going back in and doing something. So pain and swelling down, knee getting straight, those are like day one. This is the most important thing until I say it's not. And these are things that you're not just coming into PT twice a week and working on. This needs to be consistently worked on in a home, every hour, every couple hours. This is something that if you handle this well in the beginning, it's going to make life exponentially easier kind of moving forward. And then the other component would be strength. So anyone that's ever dealt with a knee injury, when your knee gets swollen, you can get what's called muscle inhibition. So essentially the connection from your brain and nervous system to the muscle, when they're swelling in it, it gets kind of disconnected. So we need to try to think of how to get that going again. So think your muscle kind of like an engine in a car. Everyone's probably had a moment where the battery's dead and you can't get it to kind of turn. We have different tools and modalities that can help kind of jump that. So we can get that jumped early, start getting good contractions and trying to maintain as much strength and muscle mass early on, the better we're looking. From there, we need to kind of manage pain, swelling, range of motion, and strength in order to get you walking normally again. If you have issues with any of those other ones, your ability to get up and kind of walk and do your normal daily activities are going to be difficult. And sometimes even with minimal swelling and pain, strength, and range of motion, you might develop some kind of habits in which your body naturally learns how to kind of offload or move away from the injury. And this is where we have other tools in our toolkit and different strategies and interventions that we can do to try to retrain your body to do that. Other things would be just preventing general deconditioning, right? You're now dealing with this injury, but we have a whole body to kind of worry about. So those are things we want to keep in the back of our head. How do we keep your overall fitness up? We know general strength training in other areas are going to be things that can help kind of prime the body in order to maximize what we're working on locally at the knee. The more we think systemically and globally, the better we'll set ourselves up. And lastly, there's a psychological component. A lot of people, sports is a big part of their identity. It plays a lot into what they do on a daily basis. And now we're saying that, hey, you're going to be out for a while. My knee hurts. I can't do the things I want to do. It's hard for me to see my friends and go out in activities. Maybe you're out of work at this time. So there's obviously the psychological and social component we need to kind of consider with all that stuff. So big things as far as early stage, and I generally tell everyone, in the early stages, we're just trying to make sure we're not digging ourselves a hole. We're going to have to get out of that hole at some point. The smaller it is, the easier it is for us. Early rehab can be really, really boring and repetitive. It's kind of like that on purpose because the most important things are the most important things, and there's only so many ways to go about them appropriately. So you have to kind of prepare people for it. This is going to be monotonous. This is not by accident. We'll get to do more exciting and fun things down the road, but we need to kind of think about the priorities are the priorities. And if we handle these well, everything else after this gets a lot easier. So I mentioned certain things we have available to us in our physical therapy clinics, different types of compression or pneumatic boots. Here we have an example of some of the things that we utilize within our company. Blood flow restriction training is a common thing you'll see now within physical therapy practice. And then in different types of surgical protocols. Essentially early on, we know usually strength training needs to be done in a certain intensity to kind of maximize outcomes. That's really hard when you got a big swollen knee and you're dealing with these things. Blood flow restriction training is a modality we have that helps us bring down the intensity, but still maximize our outcomes with that. And lastly, we have tools similar to what we would call like neuromuscular electrical stimulation. In this case, we're looking at more for it to getting kind of the muscle contracted and start getting it running again. But we can also use electrical stimulation as a form of pain management and some other strategies. So these are something you'll often see used early on in PT and something that's often not available to patients. So if we're trying to maximize the course of a year, how many visits we have, how much money do I have available to spend, utilizing these tools and maximizing our early outcomes are probably, in my opinion, one of the more important things. After this, we kind of get more to our mid stage. So at this point, as I mentioned, you're probably starting to move around pretty normal. You're not thinking about your knee too much day to day. You're walking, you're going up and down stairs. And this is where we kind of get into that next phase. And then right here, at this point, we start kind of introducing more strength and conditioning types of principles. So we want to start getting our muscles strong. Specifically around the knee, but also considering that we have a whole leg and body that we're going to need in order to do activities, and we don't want other things to get deconditioned. We know after an injury like this, your body will learn strategies often to kind of offload that leg. So then we might do some specific movement training, whether it's things like with biofeedback, meaning we can show you how you're moving and give you an idea of how to correct that versus us just saying, don't put as much pressure on that leg. And then lastly, starting to think, all right, our knees settled down, we can at least start getting on a bike or finding other things that we can do to just think about your overall fitness, specifically your cardiovascular fitness. Because what you don't want to do is crush your knee rehab and then not take care of all those other things. So when you are ready to play, your fitness is so low that you can't kind of hang with everyone else, not because of your knee, just because you haven't taken care of anything else. So this mid-stage rehab, you'll often kind of hear as like your return to running phase. The vast majority of surgeons usually clear people around 3 months. I would say often in a clinic like mine, where we have the ability to kind of measure some things more appropriately, we might delay that slightly, but you might also find settings in which we have you have some advanced tools. So in my clinic in Philadelphia, we have access to a anti-gravity treadmill, which often allows us to kind of introduce these things a little bit easier because we can control the amount of load and force going through someone. So rather than running at your full body weight, we can put you about 75% and see if the knee can better handle that as far as introducing things. If you're going to run, we have our pre-op goals still maintained. We need a quiet knee. We need a certain amount of strength. Often what can be helpful is measuring what we would consider more like relative strength. So earlier I said we want to be about 80% of the other side, but when you're dealing with a ratio, that's assuming that the other side is doing really well. So the question becomes, do you want 2 weak but symmetrical legs? Or do you want an asymmetrical leg, but one's really, really strong? And it's not like a one's right, one's wrong. I think ideally we have two strong symmetrical limbs, but the question would become relative to our size, can we handle the forces that go through the knee during running? So if I take someone's weight relative to how long their leg is, and I can measure the amount of force that they put out using dynamometry, which we'll discuss a little bit later, I know if you're around this like 2 Newton meters per kilogram mark, your knee should be in a pretty good spot. And ideally, by measuring and tracking these things, when we start new activities, because we're well prepared, we don't run into hiccups versus we just pick 3 months and say, well, it's 3 months. That means we need to just go run. And then we run. And next thing you know, you're like, hey, my knee swelled up. It's starting to hurt. And now we're kind of backtracking and trying to calm things down. If we could be mindful of our milestones along with these timelines, we can probably set ourselves up for success. And we can also think of just other drills that would be involved in preparing you for running, so more like a running prep type of thing. As we kind of get away from mid stage to late stage, a good late stage strength program should look a lot like just thorough strength and conditioning. Dynamic activities, high intensity. You're coming to PT, and when you leave, you're breaking a sweat, and you're like, that's hard. Because playing sports is hard. So we need to try to mimic that the best that we can. This is often when we'll start to introduce like plyometric and jumping activities, maybe things that are a little bit more reactive and not as planned. So rather than doing a drill in which you know exactly what you're going to do, I might utilize some tools that force you to kind of react. So we have things like blaze pods, which are lights that I might say, if this lights up red, stop. If it lights up green, go. And you're less prepared for it. And a lot of that's because when you get back to sport, it's a very chaotic environment. You don't know what the other people are going to do, and you need to react to that. And then as you get further through this rehab process, depending on where you are, if you're, in a high school collegiate setting, you might have access to athletic trainers or strength and conditioning professionals in those settings. And this is where the communication amongst the sports medicine team matters a lot. You're eventually often going to run out of space in a PT clinic, where I really view it as we're here to kind of guide things along, track things appropriately, but eventually we might need to utilize other people in order to make sure that we're using space. Like, we might not have a field in the clinic. We might need to communicate with our athletic trainer to best prepare for that. So with that, if you're someone that's injured or you have a family member and or a friend that's going through this, as you progress through these rehab stages, you really should be noticing that things are getting progressively harder and at higher intensities, because what you don't want to do is get to 9 months and you think that you're ready to go, or your surgeon says you're okay, but you haven't been exposed to these things. And if you're noticing that during the rehab process, that should be a good time to sit down with your PT and say, hey, if I'm going to be playing soccer in a couple months, I really shouldn't be on the table doing many things anymore. I should be up on my feet, moving dynamically, reacting to things, and ideally to set us up for success. So in order to set us up for success, what we want to consider is different types of return to sport testing. So we want to measure strength. And the best way for us to do that would be with some sort of dynamometry. So tools that can tell us exactly how strong you are, not necessarily relying on our hands to tell us that someone's knee's strong when that knee needs to be able to help them jump and land and do a lot of dynamic things. We also have different types of hop and jump testing that we can look at, whether it be traditionally in a horizontal plane, which we'll describe a little bit later. But now we have a lot of cool tools in our clinics, such as force plates that can tell us how much force you're putting in the ground. Are you offloading one side? And those can help us guide kind of not only are you ready to play, but if you're not ready to play, we can be very specific about the things we want to work on. And we also might utilize different kind of patient reported outcomes, some that are specific to the ACL that help with psychological readiness. So us knowing that not only physically are you ready, mentally are you ready? And I often look at it, if you're psychologically not in a place where you're ready, are we missing anything on the rehab side? It's like if I asked you to jump out of an airplane without a parachute, you'd be a little nervous. And if you don't have strength, capacity, and control, it would make sense to me why your body's kind of a little hesitant about getting to those sports. We need to physically prepare you. And then if that's not taking care of itself, then it's probably about exposing you to those environments. So you'll in our clinics, we recently partnered with our Vault Health, in which we can use the Dynamo. So you can see here how we might set someone up, rig them down, and then this tool right here can tell specifically how hard you're pushing, and we can compare that side to side and then relative to your side. Traditionally, we also have different types of hop tests, which can help us look at how far you jump, and then also your ability to kind of do that repetitively or in a crossover pattern. And lastly, I mentioned we have different types of force plates now that can tell us when you're jumping, how much power are you producing? We can look at on 2 legs versus 1 leg. The strength measures are the one that's going to dictate more of these here. So you want to make sure you're checking your boxes in order, but I'm someone that has treated a lot of these in more recent years, getting access to the force plates. I've even realized that there was a lot of things that I could have been doing better as far as your ability to decelerate and get back into the sport. So I think those are things that I've learned and why these tools can be helpful. In regards to testing, this should be something that's done serially over the course of your entire rehab process. Sometimes you might go to your surgeon, he says, go and get your testing done. And there's just a lot of things to consider with that. You know, is your knee a little bit cranky one day? Did you sleep poorly? All these things can kind of fluctuate. So it's important that you and your physical therapist are not only testing or are testing regularly to recognize if you have a bad day, that's not probably representative of where you're at on the whole. So this should be something that we're using constantly for feedback. And if we're testing and things aren't changing appropriately, then we need to recognize we might need to change the plan. So as I mentioned, 9 months is the more common thing you'll see now. We know if you return less than 9 months from your surgery date, you're 7 times more likely to get hurt. So that's why time matters. And we also know that waiting greater than 9 months to be cleared can help decrease your rate of re-injury. And that's assuming that you've also passed some of these milestones. So we have some studies that look at waiting 9 months, passing some of the tests that I described earlier, and we know that puts you at an 84% success rate. So as we're going through these, we need to consider that all the things we do in the clinic are still a little bit away from what the demands of sport are. So we try to do our best to mimic the demands of sport, but eventually the only thing to kind of do is do the sport itself. And we got to make sure just because your surgeon gives you the okay, we say you pass your test, the next day you're out there on the field trying to play a full soccer or lacrosse game. We still need to consider a full kind of progressive rehab on the field. And once again, this is really important that either the physical therapist and the rest of these members of the sports medicine team communicate really well. Up at the Temple University I work, I have a great relationship with my athletic trainers and strength and conditioning coaches, and it's very much a team-based approach where all of us are communicating, all of us are looking at different things, all of us have particular strengths within our skill set, and we kind of put our heads together to try to do what's best for the athlete. So last thing we'll kind of talk on is ideally you've handled all these things really well and you get back to sport. Can we either prevent these things from happening or at least reduce our risk? So we have some clinical practice guidelines that suggest the type of things that we should be doing within a rehab program and ideally to decrease our risk for these types of things. The timing of what we do and when we do it's really important. So it's pretty fascinating, but we have some studies that look at females that the ACL actually will thicken over the course of a training season. And that's just like most issues. If I want to get a muscle bigger, I need to stress it. Our ligaments adapt to stress as well. So this is where our body doesn't like big spikes in training. And one of the reasons why we probably see a lot of injuries during preseason. So we need to consider is what people are not only doing like from a rehab and preparation standpoint, but what have they been exposed to over a period of time, what their fatigue levels like might be on a daily basis, but also like, are they coming off a winter sport directly into a spring sport? How prepared are these things? So we need to maximize their training loads, how much they're doing, and then consider this periodization of where are they within a training season? What other things have they done? But overall, these rehab and prevention programs aren't overly complicated. Most look at something between 3 times a week for about 30 minutes. You want to make sure you're incorporating lower body strength, core and plyometric exercises, and with time, maybe some additional balance. And they've been shown that you can do these either like before, breaking within, or at the end of training sessions to try to maximize or tag these on to activities you're already doing rather than trying to find time or another day to do these things. There are a lot of open access programs that are out there. So the FIFA 11 or the FIFA 11 Plus is something that you can find online, and the PEP, so the Prevent Injury Enhanced Performance, is another one. So hopefully at this point, ideally no one gets hurt, but things happen. We've kind of taken them from the prehab all the way through a good program, including some field-based rehab. And if they are back, keeping in mind ways we kind of keep them on the field. And if you do all those things, hopefully we'll end up in a position when you don't have to spend too much time with people like me.